and Memorial Chapel and Cox and Graziano Funeral Homes. Jennifer is here to discuss a sensitive subject we all need to talk and think about. Here now is Jennifer Graziano and Time to Talk.
Good morning, Westchester. It's 9 a.m. on Monday, and that means it's time to talk with me, Jen Graziano. I'm a licensed funeral director who oversees my family's funeral homes, Cox and Graziano of both Mamaroneck and Greenwich, and the Zion Memorial Chapel of Westchester. Every week, I come to you discussing important topics and sensitive matters that all of us need to pause and reflect upon at some point, and through this show, I hope to provide a platform to do so. We will take any questions, comments that you have this morning to 914-636-0110, and I'm sure there might be something you'd like to ask my guest. He's a returning guest, part 2 of the show that we did last week with Dr. Jeffrey Puglisi, a board-certified internal medicine physician and the founding partner of Glenville Medical Concierge right over the line in Greenwich. He specializes in clinical interests such as men's health and cardiovascular disease prevention, but he is a concierge physician. And what that means to you is personalized, dedicated care, a care at a level that you cannot get from going to a big group. But he's back with us on the line, and I welcome you, Dr. Puglisi.
Good morning, Jen. Thanks again for having me, and I really appreciate that all you do for your listeners.
Thank you so much, and you for your patients as well, and communities at large, because you really do take your message out on the road, and there's a strong education component to your mission, so I credit you for that. There simply wasn't enough time to talk last week. There was so much to cover, and the state of corona really changes week to week in how it's impacting our lives. So you see a lot more restlessness this week. We see a lot of studies suggesting that although the virus, no one can detract from the severity of it and the impact it's had on this epicenter region that we're living in. But there are numbers and models to suggest that it's not going to cause the fatalities once believed, the infections once believed. And a lot of people are sitting home not knowing where to fall with their trust. So we're hoping that you can help break it down for us again, and talk. And just to give a little bit more background on you, you've been named as a top 25 doctor in the nation for concierge medicine in the 5th year in a row. So certainly, folks, we do have an expert here joining us this morning. Congratulations to you, doctor.
Thank you so much, Jen. I credit that all to my staff, my partners, my family. You need support in whatever career or profession you've chosen to be able to achieve success. I consider that success to be shared by all of us. And I think that having an opportunity to speak to you again just allows me to educate more and more people, more than just the individual patients that I have in my practice. So thank you again.
You're so welcome. I want to start with symptoms because we have been told for so long this is respiratory and, this is going to be something where there's a fever and a sore throat. And that's how it was rolled out initially. But what we're finding is that people who have been tested positive for COVID are experiencing a range of symptoms, everything, including neurological symptoms of strong headaches. I actually spoke to someone yesterday whose sister-in-law was infected, and a massive headache was the primary indicator for her. Can you talk about the neurologic symptoms of COVID?
Absolutely. We touched on this a little bit last week, and it's so fascinating how quickly our research and our science is taking shape and taking form each week as the coronavirus infection continues to be among us. And we're learning more from other countries and nations that have been dealing with this. When you look at some of the data coming out of China, up to 45% of patients presented with some neurologic symptom. Doesn't mean that it was singular. It can be associated with other symptoms that we classically see with COVID-19, such as fever, chills, fatigue, sore throat, cough, chest pain, and breathlessness. Those are the ones that we clearly still want to be focused on. But I would say to anyone that's listening, from here on out, until we have a vaccine, until we have herd immunity, until this is behind us, if you're getting new onset acute symptoms of severe headache, of brain fog, of vertigo, dizziness, changes in vision, ringing in the ear, tinnitus, balance issues, ataxia, numbness, neuropathy. Obviously, if somebody has a stroke or seizure, we're going to be thinking of other things first, but keep it on the differential diagnosis as well. these are symptoms that we're seeing more commonly than we thought we would. A loss of sense of smell and taste is also, I think, an olfactory nerve issue, which is neurologic. And what I think needs to happen, Jen, is we need to push this forward in the science and the treatment modalities, because if we think about this as just a pulmonary disease and do everything we can to save somebody from their lungs getting worse, I think we may be missing the boat. And there are treatments that I think need to cross the blood-brain barrier to get into the brain that might be just equally as effective, and that may open up a whole new treatment armamentarium. So keep an eye out for the neurologic symptoms, both patients and physicians, and I think we'll pick up more patients that may have the disease than we would have prior.
I agree. I think we did touch last week briefly too. A friend of mine who's a physician's assistant at White Plains Hospital was saying, we need to look beyond just respiratory issues. There are other factors involved here. So, Dr. Puglisi, we do know, hospitals are just the last place you want to be. ERs are certainly just the last place you want to be right now. So what is the trigger with one of these neurological symptoms that moves you from your home to the emergency room? Is it, obviously, the stroke signs are different. Like you said, there could be something much greater going on with those. But if you're having a severe headache, a severe migraine, loss of vision, is there something else that in furtherance that's going to make you go to the emergency room, or is there a danger of people trying to treat that with taking an Advil?
Right. Well, listen, I would say to the individuals who have had chronic headaches in the past, chronic vertigo in the past, having a new onset of those symptoms does not indicate that it's COVID, because those people have a higher predisposition to having those symptoms in general. And it's not something where they should rush to the emergency department if they get it again. For individuals who have not had those symptoms, who get them for the first time, I really want them to key in on this topic. 9 times out of 10, those symptoms, unless they're stroke or seizure, are not going to get you to call 911 and go to the hospital. Truthfully, most of these symptoms are going to be mild to moderate and are going to probably be in the constellation of other symptoms that we've mentioned. That requires a phone call to your physician. Let's be clear. Part of the reason why I'm so strong about the concierge model is that the accessibility to a physician when you need them most is the key. And so if patients have these symptoms and they're concerned, you need to speak to your doctor, and you need to put it into the context of what the symptoms actually mean. Have you had this type of symptom before? How long does it last? What you've used to treat it? And when we go through that algorithm, we can determine whether someone's sick enough to need hospital care or not.
I think it's important to take a step back and have, a strong self-awareness. Know yourself, know conditions you've experienced in the past. We don't want to rush to panic, but you need to be mindful of what is going on. So, a thoughtful intake of what you're experiencing and how frequent or regular it is for you. But like you said, the connection to a physician that's going to answer the phone. I mean, it's hard enough to see your doctor in person, but to get him on the phone it's something that can't be underscored for sure. Dr. Puglisi, let's talk about how the virus travels, because again, there's so much that we hear that it could transfer, ocularly, on surfaces, airborne. We can pass each other on the street, and they kind of describe these scenarios where it's going to jump off one person to another. Again, where does the truth lie in that?
I think the truth lies somewhere in between the droplet hypotheses and the aerosolized hypotheses. What do I mean by that? When you take the most virulent infection we know, measles, and you understand how it transmits itself, and the reason why we're so concerned about measles in general and have been for many, many years, is that it can infect up to 14 or 15 people just by that one person having measles. And the way it does it, it's almost a perfume cologne effect. And what do I mean by that? That analogy basically means that if you're near somebody that has measles and their virus gets aerosolized into the air, it's like you've sprayed cologne or perfume in the air and then left the room. And then someone walks in behind you and smells that somebody was just putting perfume in the air. It means that those droplets are sitting there hanging out, particularly if there's not much cross-ventilation. They're hanging out waiting to latch on to someone else. That is the worst case scenario of any virus. Do I think that that's how COVID-19 actually spreads amongst individuals? I don't, but there may be more of that that's happening than we know. And there are some studies that have shown, case report studies, in China where there was a bus full of people, and the index case person that had the virus infected 13 other people. The furthest away from that individual was about 14 feet. Now, clearly, it could have been something that they touched the surface that passenger had touched. But there was also some data from ICUs out in China where they saw a virus 13 to 14 feet away from an individual in the bed. And that just tells us that perhaps there's the possibility that in the right settings where there's not a lot of cross-ventilation, there's a lot of stagnant air, that virus might be hanging out a lot longer than we think. So the mask phenomenon that I think is going to be with us for many, many months, something that I want everyone to be comfortable with, understand what it means, and take precautions out there. Even if you think that the risk is low, even if you have that 6-foot distance, let's not take any chances, because the time that you take a chance is the time that you get infected, and you do not want to be one of those individuals that get the severest form of this virus, and that's what we're trying to protect people from. So even though the droplet phenomenon is where you would talk or cough or sneeze and it would kind of fall down in front of you, presumably in that 6-foot radius, I just want to caution everyone that there may be something else out there that is a little bit more devious, and the reason why the virus has been so apt to spread amongst so many people nationwide and worldwide.
The contagious nature of the virus, Dr. Puglisi, is this the ultimate factor that sets COVID apart from from the flu, the common cold? Does it just spread with a vengeance, or is it because it's new and unknown? I mean, this is something that has just rocked our world, changed life as we know it, but crippled us, paralyzed us. Is it because it just spreads with such fierceness and intensity, or do you just find more that, in 10 years from now, when we understand COVID, it's not going to seem to spread as much or be as contagious, or, then again, we'd be vaccinated. But what are your thoughts on that?
Yeah, I think that's a great question. And truly it lies somewhere in the fact that it is a very contagious virus, clearly. But there are many out there that are contagious, and we don't lock down the country for it. It has to do with the contagiousness, the severity, the mortality rate that we've seen throughout the world, but also the fact that it's a novel virus. We've seen coronaviruses in the past that cause the common cold. And maybe you miss a day of work, maybe you don't. Maybe you just take precautions, maybe you don't. But it's not like the mortality rate is super high. In this particular virus, it's the ferociousness of it that is the reason why we've taken so many precautions and why we've had shelter in place and why we've been so aggressive about it. It's because of the combination of how infectious it is, but also how dangerous it is. We'll talk later about antibody testing, which everyone was hoping, I was as well, that it would be the holy grail of testing. It would give us this idea that we're immune, that we're somewhat impenetrable from having future infections. It falls short of that, and I'll talk to you about why that is. But at the end of the day, part of the reason why this virus hit us so hard is that we did not have much in the way of immunity coming in. And I think that's the reason why so many people, including young individuals, are affected so much. Interesting story, when you go back in history, you go back to the Spanish flu in 1918, 1919, some of the older individuals in our country were not as profoundly affected. And one of the theories was that in the late 1800s, there was an epidemic of flu that happened, and those individuals that survived it actually probably had some passive immunity in their body still when the Spanish flu came around. And so that probably helped them to fight off the severity of that illness. Right now, we are all pretty much sitting ducks in terms of being affected to the same degree as everyone else around us, because we don't have that predetermined immunity that helped a lot of those individuals back in the early 1900s.
So let's go there, doctor. How will you ever acquire passive immunity by being indoors? If you've been in your home now for 6 weeks, the people in your home have been with you and no one's been exposed to anything. When we are allowed out of our homes and when life takes on something normal, the virus will still be there. So without letting people, in phases out, obviously, I'm thinking of you're agile and healthy, how will we ever gain our passive immunity, our herd immunity? Because the virus isn't going away, and our own bodies need to be equipped with the armor to fight it.
Well, look, if we didn't have an economy to run, we would stay indoors until we had better treatments or a vaccine. I mean, that goes without saying, but that's not the reality. Obviously, we can't allow an economy to crumble in front of us, because that may lead to more deaths long term as it relates to poverty, as it relates to violence, as it relates to so many different avenues that we're not even considering. So I'm a fan of trying to figure out a compromise where we're getting people back safely, but trying to advance the science to the point where we have better treatments. If you said to me, Jen, right now that we had a treatment that kept people from needing ventilators, if that's what was actually the case right now, I would feel much different about just allowing everyone back to work. Right now, we do not have that medication or medications. We have some signals that there are medicines out there. There's even the possibility of convalescent serum, these antibodies that are pulled from recovered patients that may be very, very helpful. But right this minute, we don't have that data that suggests that we have a get-out-of-jail-free card and we're going to prevent someone from getting super sick and needing ICU care on ventilators. And until we have that, I'm going to be very nervous and very scared, not only for individuals out in the community, but for myself and other healthcare workers and my staff and others that I've been trying to protect so much during this process. And I think we're going to have, the worry I have, truthfully, is that we're going to have this sawtooth pattern to the incidence of this disease, meaning we'll control it now. We've seen a plateau and now a decline in some of the numbers in the tri-state area. We allow people out in the next number of weeks, whatever it may be, and then we see an increase infections in the community. We shut back down. We go back up. We shut back down. And there's going to be this sawtooth pattern to it, which we saw in the Spanish flu as well. We saw a couple of different spikes in terms of infections. And some of the areas you can read about it, Philadelphia was one, particularly that had a parade in the fall of 1918 or 1919, I forget the year, where hundreds and hundreds and hundreds of people were infected because they defiantly had that parade and got many people sick and then ultimately perished. I think we just have to be really careful about how we go about this, make sure that employers and restaurants and everyone else understand that there is a public health emergency going on until this virus is gone or until there are treatments that are better, and we all have to do our part. And that's kind of the way I would say it.
So we want to mention also, like you said, numbers are going down for hospital admissions, less patients in the ICU. You've indicated to me through our notes that Greenwich Hospital is seeing over 200 patients that have been discharged in the past weeks. So it's all good signs. It's moving in the right direction. But some of the risk factors that are, again, as you mentioned, we're learning more and more, and the science is coming quickly, which is a good thing. But there is a nexus between obesity and COVID. And that is true, and I can even attest to that from my professional realm as well. Obesity brings about risk factors for so many other diseases. Is it the cardiovascular risks that it imposes, all the diabetic health risks? Is there something unique, or is it just the traditional model that obesity brings about so many other possible health concerns?
I think first and foremost, it's the pro-inflammatory state that somebody who is overweight that may have pre-diabetic tendencies, they're already inflamed. And this is a disease and an infection of inflammation. That cascade of cytokines that I mentioned last week, that pro-inflammatory state that attacks the lungs, that attacks the brain, attacks the heart, etc., it leads to a more devastating consequence. And I think that someone who is obese is coming to this infection with much higher risk. And you add to that individual any hypertension, diabetes, sleep apnea, heart disease, etc., which are more likely to happen in that population, then you've already known for many months that those comorbid states are increasing risk of mortality. So the message I would send to everyone currently is that take this opportunity, as much as we're afraid and stressed and having cabin fever, take this opportunity to look inward, to be as healthy as you possibly can, to change your diet when you're home. You have the ability to exercise more, put in a routine now that when you're heading back to work in the coming months, that routine is in place, that you've lost the 10 or 15, 20 pounds that we talked about, that you stay away from substances. It is so easy to step into alcohol as a sedative, as a way to come down from the level of anxiety of watching news shows and hearing all this day to day. Step away from that. Let's try to treat our bodies differently during this pandemic so that when we come out of it, we're healthier than we ever have been. And if we do get infected, God forbid, in the future, that we're much more likely to have a mild course.
It's so true, but you can see the temptation to go the other way. It's hard to be home. For me, it's actually renewed my commitment to health and exercise, but I can see the other side of that, and how it can go the other way. So in terms of antibody testing, we hear about COVID testing, and most people aren't tested until they're symptomatic. So just being near someone doesn't qualify you for a test. The false positives, I was actually discussing this with my boyfriend's a physician, and he said the same thing of finding in this article. Talk a little bit about the testing we have available.
Well, the difference between last Monday and this Monday is fascinating. Because last Monday I was so hopeful that the antibody test would be the way that we could determine what the prevalence in our society was and be able to get people back to work. The problem is that the false positive rate of that test is so high because the prevalence in our area is so low. There's an interesting article by Richard Harris in NPR recently. It was last Tuesday. I'd like everyone to take a peek at it and go down to the bottom of the article where they have three different boxes, one that says prevalence, one that says false positive rate, and then another that says the chance that a positive antibody test is incorrect, is wrong. And as you toggle the prevalence rate, which I think is probably going to be someplace around 3 to 10 to maybe 15% in our area. It'll be less in perhaps the middle portion of the country, more on the coasts, metropolitan areas. And then you throw in the false positive rate of the test. That's the specificity of the test, which basically is anywhere between 93 and 97%, give or take, on this test that are being made, marketed very quickly right now, and we have to be careful about these tests. So I chose 95%. So a 5% false positive rate, a prevalence of 5 to 10%, you're going to get between 1/3 and 1/2 of every single antibody test that you get back that's going to tell you the wrong information. How dangerous is that? If a patient comes to my office and I tell them that they have a positive antibody, an IgG antibody, which is a memory antibody that doesn't really even form until about 3 or 4 weeks after you've been infected, that's another topic altogether. But if I say to that person, you're immune to this virus, and they go out, they go to work, they do the shopping for their family, they go and see their parents, take care of their older parents, and they get sick and get everybody else around them sick, I've done them no service at all. In fact, that I've propagated this virus. And I think we're all waiting for the best test possible to tell us that we're immune. I mean, every patient in my practice probably wants this test. I would. If it was a perfect test and it could tell me that I had an asymptomatic infection and now I'm immune to the virus, sign me up. The problem is that we're getting between 30 and 50% inaccurate tests. We have to be careful. There may be a way that we stage this a bit, where we have individuals from certain families that have had 1 or 2 members in the family that have been infected. That increases the prevalence within that family. If you have a couple and one of them has been infected, well, the prevalence in that little world, that home, is 50%. That's going to increase the likelihood that that test is going to be meaningful. It'll lower your false positive rate. So we may take certain situations, start doing the antibody tests on them, and then broaden it out when we have better tests in the coming weeks. But to anyone listening, antibody testing, if you do get the test, a negative result may be helpful. A positive result requires a long conversation with your practitioner, and I'm not sure I would even say to that person that they are immune. And that's an unfortunate thing to say, but that's just something that everyone needs to understand clearly before you get the test done.
Are we going
also,
to
one other thing, Jen, there's a New York Times article out this morning that basically enumerates all that as well. It doesn't have the graphical models that I was telling about in the NPR article from last week, but it can certainly give you some other insights into the antibody world.
Are we going to be seeing, the at-home test similar to the diabetes where you prick your finger? I mean, is that something that's on the horizon for us at home?
I think so. I think in the future we're going to have testing that comes to the house. I'm hoping that it's going to be the actual viral test, the PCR, to look for active virus versus the antibody test, unless the antibody test gets much better, because I really want to know who's infectious. That's the most important thing. The problem is you can't test 300 million people every single day of the week, and therefore there's going to be some inherent risk. But if we had enough swabs here at my office, I would do it on every single patient as much as I possibly could to determine if they're carrying virus, because then we would know to isolate those individuals And understanding who's infectious is how you protect others around them from getting the illness. And so to me, I mentioned the term flat-footed last week. It's just because we haven't had the amount of testing capabilities that we needed to attack this. We're getting better and better, but we really have to get to a point where it's easy to do at home. We're not there yet. I'm hoping in the coming months that's possible.
Dr. Puglisi, remind our listeners this morning where your practice is located and how they can get in touch with you.
Sure. It's Glenville Medical Concierge Care. We're in the Glenville section of Greenwich, Connecticut. Our phone number is 203-531-1808. You can find us at glenvillemedicalconciergecare.com. And feel free to reach out anytime. We're more than happy to talk about any of these issues. There are 4 physicians here that are working tirelessly to keep our patients safe. And Jen, it's just such a privilege to be with you these last 2 weeks. And thank you for everything that you and your family have done for your community.
And I thank you again, and I know you will be back on the show because you have such wonderful things to contribute. And as we close, I just remind everyone to really consider the concierge model of medicine because it is first-class care. And in times like these, we need to be able to speak and connect to our physicians, discuss symptoms, and also have them act as our advocates. Someone that we know is hospitalized or is on that brink, you need to be able to speak to the right people. So Dr. Puglisi, I thank you so much for your time.
Thank you.
And this is Jen Graziano thanking you for taking the time to listen as we took the time to talk. Have a great day. Stay safe, stay sane, stay strong, and this too shall pass. Bye-bye, everyone.
Next on the Capital Connection, State Senator Julia Salazar.